So hi friends, we are going to discuss FMGE January 2026 paper. Around 24 questions came in FMGE exam. So it's a moderate paper, not so easy, not so tough also. So let us see the questions one by one. I have divided the section-wise discussion. So the first question on a road traffic accident, patient presents with sudden respiratory distress, trachea deviated to the opposite side, hypotension, absent breath sounds on the left side. So there is no breath sound on the left side, trachea is deviated to the right side. Just X-ray is shown below. What is the initial management of this patient? So you can see here there is a tension pneumothorax. This is a classical image of tension pneumothorax, and you know this is a multiple times repeat MCQ. And there will be no FMG paper without a discussion on tension pneumothorax. So for a tension pneumothorax, the first aid or the first treatment is, the next done treatment is a tension pneumothorax. It's a red emergency in the triage. So immediately I should put a needle. Needle is usually put in fifth intercostal space at mid-axillary line in adults. A needle is put in second intercostal space in mid-clavicular line in children. So these are the places where we put the needle. The needle is put in any one of this place, and this is not the immediate treatment of choice. The treatment of choice is plan to put an intercostal drainage tube at fifth intercostal space mid-axillary line as early as possible. So initially you can put a needle and deflate the bulging air. So this is a very important thing because the lung is getting compressed. Patients will develop hypotension and shifting of mediastinum to the opposite side. So plan for intercostal tube as early as possible. In this question, the answer is needle compression at second intercostal space mid clavicular line. This is a old MCQ, old edition, old ATLS guideline, but actually we have changed it from second to fifth intercostal space. So if you get fifth intercostal space in adult, that is the best. Fifth intercostal space in mid-axillary line is the correct answer in adult. So 25-year-old male presents with road traffic accident. He has hypotension, warm flushed skin and loss of sympathetic tone below the level of spine. So MRI spine is shown below. Which of the following is a characteristic feature of neurogenic shock? So there is a transection of the spinal cord from the picture. From the MRI, you can see there is a transected spinal cord at the neck level. So there is an injury here. So the patient is developing a neurogenic shock, and this is also another repeat question. In all the shocks, there will be tachycardia and hypotension is the feature of all the shocks. Most of the shocks, let it be hypovolemic shock or cardiogenic shock, or most of the shock will develop tachycardia and hypotension is most common presentation in most shocks. The only shock in neurogenic shock due to the vagal attack, so vagal injury, that is a bradycardia. So this is a multiple times asked MCQ. Bradycardia plus hypotension is a classical feature of neurogenic shock. So and hemorrhagic shock will have cold peripheries. Will have a cold peripheries, whereas a neurogenic shock will have a warm periphery. Neurogenic shock, septic shock or other forms of distributive shock will have a warm peripheries. So from the question you can see that is also given in the question. So in the question they are mentioning very clearly. So warm flushed skin. So this is therefore a bradycardia and hypotension. Answer is C is the answer for this question on neurogenic shock. This is also a repeat question in FMG exam. 28-year-old man is brought to emergency room with a burn trauma. So it's a burns is a trauma. With the burn injury, he has come to the hospital with the burns trauma and involves neck, upper chest and face. So he is alert but tachypneic, singed nasal passages, the hairs in the nose are all burnt. And when you are opening the mouth, you are seeing the soot particles are nothing but the fire particles are seen in the oral cavity. The saturation is 80%. So this is a case of carboxyhemoglobin elevated, means this is a burns induced respiratory damage. Respiratory system is affected. So in any trauma, the routine protocol is A, B, C, D, E. This is the routine protocol of any trauma. So A stands for airway and spine control, and cervical spine control is standing for A. So B is for breathing, C is for circulation, D is for disability, and E is for exposure. So this is the typical A, B, C, D, E we always read in trauma. So this patient is having airway compromise. So what should I do? As early as possible, oxygen therapy will be started, but proceed with endotracheal intubation as early as possible. That is the most immediately done. Intubate him immediately. So fluid resuscitation and all will be done later, in the later part. First thing is airway. If there is an airway compromise, without wasting a minute, put a tube and put oxygen through the tube. That is the answer for this question on trauma. This is also a repeat concept. Okay, repeat concept. So this is a totally new question for FMGE exam. Though it is a very commonly asked INISET question, this is a new concept. A patient comes to emergency with a stab injury in the neck. There is a stab injury in the neck extending from angle of mandible. From in this place, it is extending towards here. There is a stab injury here. On examination, there is air bubbling from the wound. What is the most appropriate management? So this is air bubbling from the wound means there is an injury of trachea being cut. Trachea is cut by the knife. So it's a tracheal injury, air is coming out. So therefore, I should immediately operate this case. So this is called as zone 2. So from the picture, you can see there are 3 zones of neck injury. Zone 1 is from sternal notch to cricoid cartilage. Sternal notch to cricoid cartilage. Zone 2 is most commonly injured zone. Most common injured zone in penetrating trauma is zone 2. Here, please remember, it is from cricoid to angle of mandible. Angle of mandible. This is a new question in FMGE exam, no doubt. And zone 3 is from angle of mandible to the base of skull. Angle of mandible to base of skull. So in zone 2, majority of the vessels, majority of the structures are seen in zone 2. Like trachea is in zone 2. Trachea can be injured in zone 2. Carotid artery can be injured in zone 2. And IJV can be injured in zone 2. Esophagus can be injured in zone 2. All these injuries will happen usually in zone 2. Any zone 2 injury, we have to immediately explore. Urgent surgical exploration is done at the earliest possible. Surgical exploration is done at the earliest possible in zone 2. So zone 3 is least accessible zone. Least accessible zone. The reason is, this is a small area. If there is any injury, I cannot access. The carotid artery will retract into the skull and IJV will be difficult to repair. So least accessible zone is zone 3. So most commonly injured zone is zone 2. Least accessible zone for surgery is zone 3. So please don't forget a case of cervical zones, neck zones in penetrating trauma. So this question is asking about injury in this zone. So we have to do urgent surgery. Yeah, urgent surgery needed for zone 2. From cricoid bone to angle of mandible. Angle of mandible to base of skull is zone 3. Okay, don't forget this basic question. 4th is a new question. 5th is a repeat concept. A patient developed a road traffic accident, presents with a crush injury of the limb. Based on the disaster principle, what is the triage category shown below? So this patient is having a triage category shown below. Is a classical compound fracture. Compound fracture with a crush injury of lower limb. So this patients will come under which triage? This comes under yellow triage. This is a direct table in Bailey and Low. I have took the table directly from Bailey and Low. So red is a patient who needs treatment within 30 minutes. Yellow is a patient who needs treatment in 1 to 2 hours maximum. Within 1 to 2 hours. Green is walking wounded. Black is moribund and you cannot save him. So there has been already questions from green. Green is simple fractures and minor lacerations. Come in green. Simple fractures, minor lacerations. We should put a small band-aid and ask them to go to their native place for treatment. Severe brain injury. Extensive burns more than 30% or 40%. Loss of chest and abdominal wall structures. That is a run over the chest, run over the abdomen. So fully there is a crush injury. In such cases we cannot treat. And this case is a case of compound fractures. compound fractures, degloving injuries, abdominal viscera perforation, pelvic fractures, spine fractures. All this comes under yellow. So please don't forget yellow color things, because red is easy to remember. Tension, pneumothorax, pericardial, tamponade, brain injury. All those things you can easily remember. See, severe facial trauma, tension, pneumothorax, excessive bleeding, hemothorax, flail chest, major intra-abdominal bleed, extradural hemorrhage. All these cases you can treat within 30 minutes. And this case is a case of compound fracture. So please remember degloving injuries, compound fracture, abdominal organ perforation, abdominal viscera perforation, like a duodenal ulcer perforation, gastric perforation, any perforation of any abdominal viscera also comes under this. So these are all coming under yellow color batch. So triage means sort out according to the severity. Triage means sort out according to severity. According to severity is called as triage. So don't forget triage. Triage is a repeat question for exams. So these are the 5 questions from general surgery and trauma. Coming now to the head and neck. This is also a new concept. Might be a little too much for a FMGE exam. This is a initiate level question. 45-year-old woman was diagnosed with a ductal cancer in situ. Not ductal cancer in situ, where the tumor has not invaded the basement membrane. And you are doing lumpectomy called as breast conservative surgery. Histopathology revealed a very close margin of 2.5 mm, because the ideal margin for any tumor is 10 mm or 1 centimeter. That should be at least 10 millimeter on all the sides. For example, this is a tumor you are removing. This is a ductal cancer in situ you are removing. We should have a margin of at least 1 centimeter on all dimension. 10 millimeter margin is needed on all the sides. But this patient had a margin of 2.5 millimeter. So therefore, what we usually do for a close margin is we redo resection like this. So whichever side there is a close margin, we will redo resection. In this question, she underwent a re-resection, but still the margin remains very close. Still the margin is not 10 millimeter. So margin is not more than 10 millimeter from the tumor on second excision. So for example, if this is a patient of ductal cancer, please understand, ductal cancer means I would have gone for a MRM, mastectomy. If the margin is very less on 2 times, I would have gone for a MRM in a ductal cancer. But the catch point is this is not ductal cancer, this is ductal cancer in situ. What will I do now for this patient? This is a very old initiate question called as Van Nuys grading. Now I will follow Van Nuys grade and I will decide what should I do after the surgery. So that is based on Van Nuys grading. So Van Nuys grading says, if the size of the tumor is 1.5 centimeter, 1.4 centimeter, more than 4 centimeter, or grade of the ductal cancer in situ, low grade, high grade or very high grade, margin, see, ideally we should have a 10 mm margin. If the margin is 1 to 9 mm or less than 1 mm, and see the age of the patient, more than 60, 40 to 60, less than 40. So based on size, margin, grade and age of the patient, we have given points for the patients, and if it is 4, 5, 6, we will, whatever we do, lumpectomy is sufficient. If the points are 7, 8, 9, we have to give radiotherapy. Mastectomy is done for 10, 11, 12 points. So from this question, we cannot come to a proper grading because we have no other data. So maybe 45 years, we can give some 2 points. So we can give 2 points for 45 years and we can give 2 points for 1 to 9 mm. But otherwise, the size of the tumor is not mentioned here. So size, let us assume from our practical point, assume size is some 1.5 centimeter. So I give 1 point for this, and it is a low grade tumor. So low grade tumor, 1 point, 1 point and 2 plus 2, 6 points. So depending upon if the points only we will decide. So from the points, if it is a 4, 5, 6 points, whatever you did, this is enough. Based on this, if 4, 5, 6 points, no further treatment needed. If it is 7, 8, 9, I should go for a radiotherapy. So I should go for a radiotherapy. So in this question, from whichever available factors, I think the examiner might have wanted you to answer adjuvant radiotherapy to the remaining breast. So we will give radiotherapy to the remaining breast will be the answer in this question. So though the question is not fully focusing on Van Nuys grading, this is a straightforward question. When the margin is very close, go for adjuvant radiotherapy is a old concept, and this is the same question asked in INICET exam. So this is based on Van Nuys grading. Definitely this is a too much question for FMGE exams, I am sure with that. So Van Nuys grading, adjuvant radiotherapy should be given for those patients. This is a typical repeat question. A 48 years old woman presents with a painless lump in the right breast. You are going to stage the cancer now. On examination, the lump is 4.5 centimeter. Okay, the lump is 4.5 centimeter as a T staging. So T staging is therefore T2. T1 is less than 2, T2 is 2 to 5, T3 is more than 5, T4A is involvement of chest wall or skin. This question is very clear. There is no evidence of chest wall or skin involvement or no distant mets on clinical examination as well as on imaging. So therefore it is T2 only. And there is ipsilateral mobile axillary nodes like this. So there are some mobile axillary nodes. I will give N1 for this case. So T2 N1. So this is a case of T2 N1. So stage grouping. Stage 1 is T1 N0. This is stage 1. 2A is when you count it should come to T1 N1 or T2 N0 is 2A. 2B is T2 N0 or what is T2? It is T2 N1. When you count it should come 3. T3 N0. So please remember, when I count, if it comes 1, if it comes 2, if it comes 3, this is called as stage 1, 2A, 2B, and stage 3A is all the others. All others. 3A. 3B is any T4 comes under 3B, any 3C comes under any T3, N3, and 4 is any M1. So this is a stage grouping. See, usually the examiners will ask only TNM staging, and in this exam they have asked you to stage group. This is American Joint Cancer Committee stage grouping. So from the question it is T2N1. So I will go for T2B. So T2N1. So their stage grouping is very simple. When the count T and N comes 1, it is 1. 2, it is 2. A. When it comes 3, 2 plus 1 is 3. Therefore it is 2B. So, and apart from this, any T4 comes under N3, 3B, any N3 comes under 3C, any M1 comes under 4, and all others are put in 3A. So, what are the all others? T1, N2, T2, N2, like that. Whichever comes, you can put it here. T3, N2. So, all others, whichever you feel, put under 3A. So, this is 2B from the question. 22-year-old male presented with a maxillofacial surgery OPD with a painless, gradually progressive swelling at the base of the tongue for the past 6 months. On oral examination, a smooth, bluish, cystic swelling is seen on the floor and extending to the base of the tongue. This is a very commonly asked MCQ, and all of you know the answer. It is ranula. So, ranula is a mucus extravasation cyst. Mucus extravasation cyst of sublingual salivary glands, It's a mucus extravasation cyst of sublingual salivary glands. Ideal treatment of choice for this case is excision of the salivary gland. Excision of the sublingual salivary gland is the treatment of choice. And new treatments are available now. Once upon a time, they used to do marsupialization. That is no more done. Excision of salivary gland is ideal to prevent recurrence. So, recurrence, if you don't want recurrence, you should go for excision of the gland. A new concept is, now there are new treatments available. Injection OK432 can be injected into this. You can inject OK432 into the ranula, aspirate it and inject OK432, or Botox can be also injected. So, OK432 or Botox are nowadays used to treat the ranula. New update from 28th edition. Just remember the new points, but excision of the gland is the ideal treatment for ranula. A middle-aged woman presents with persistent dryness, itching and eczema. That's a clue. Eczematous changes over the nipple. The nipple gets eroded because of the eczematous change. The lesion does not respond to topical steroids. People think it is as eczema and they use steroid, but it is not responding. So a nipple biopsy was done histopathologically, that is shown here in this picture, and it is showing you what type of cells. This is a pathology cum surgery question. So these are called as Paget cells. Paget cells are large vacuolated cytoplasm. So this is a commonly asked MCQ. Paget's disease will have the following clinical features. So Paget's disease is a disease involving nipple, in which nipple gets eroded, and there will be discharge coming from the nipple level. So what we should do is, we should take nipple biopsy. So nipple biopsy should be done, and it shows the Paget's cells. That is the investigation of choice is nipple biopsy. See, there are two types of Paget's disease. Many times it's a tumor involving only the direct nipple. This is only involving here. This is coming under ductal cancer in situ, and this comes under TIS grading. So only it's a in situ tumor. If there is only a tumor involving the nipple, it is in situ grading. There is another reason for Paget's, that is having a huge tumor, a huge mass in the breast which infiltrates into the nipple and causing erosion is also a Paget's. So this is based on the T staging. Based on T size, we have to give a staging for this case. So there are two types of Paget's disease. One is confined to nipple. Another is with the underlying tumor. So a case of underlying tumor, the treatment of choice for this case is MRM, modified radical mastectomy. For this case, the treatment of choice is excision of the nipple. Okay, excision of nipple alone is enough for this case because it's an in situ tumor. So just give a margin and excise the nipple, that is enough for the first case. So there are two different types of Paget's. Paget's confined to nipple and Paget's due to an underlying tumor. In whatever it is, both the cases nipple is eroded, looking like an eczema. Okay, don't forget this point. A 10th question, a chronic tobacco user presents with a non-healing ulcer on that lateral margin of the tongue. There is a non-healing ulcer. So for a long period of time, if there is a non-healing ulcer which is painless in the mouth, means we should rule out cancer. So rule out cancer. How will you rule out cancer? Take a wedge biopsy like this, including a normal skin. This is normal skin, this is cancer. Like that, we have to take a wedge biopsy. So usually the wedge should include the normal skin. How we take usually is like this, I will take. So majority of the tumor part and normal part will be taken like this, and this is wedge biopsy. But Bailey does not mention as wedge biopsy. Bailey says this as incisional biopsy. Incisional biopsy. The answer is wedge biopsy should be done to confirm the diagnosis, and most common histology for this cancer is squamous cell cancer is the most common histology, and the most common pre-malignant lesion is leukoplakia. So white patch which cannot be rubbed out, it is called as leukoplakia. So white patch in the mouth which cannot be rubbed out is the most common pre-malignant lesion, and most common risk factor of oral cancer is tobacco in any form. Tobacco in any form is the risk factor. So don't forget, most common infection associated with oral cancer is human papilloma virus. So human papilloma virus is one of the important reasons for seeing a oral cancer in practice nowadays. So don't forget this case of squamous cell cancer. A patient presents with recurrent episodes of pain and swelling in the submandibular region. So please understand, submandibular gland is superficial lobe, deep lobe, and this is a submandibular duct called as Wharton duct, which opens in the under surface of the tongue. It is opening here. This is duct. So the patient, the history is showing, in this image shows there is a stone in this place. It's around 1.4 centimeter stone, very big stone in the duct. 1.4 centimeter duct stone. Along with this, the patient is also having inflammation of the gland. So not only there is a duct, there is also silodinitis. See, there are multiple options in this. Duct only contains stone. Duct stone less than 4 mm can be removed by cyeloadenoscopy. Removed by cyeloadenoscopy. 4 to 7 mm stone in the duct can be broken by extracorporeal shockwave lithotripsy followed by cyeloadenoscopy. If it is more than 7 mm duct stone, you can lay open intraoral way, lay open the duct. Lay open duct. So open the duct and take out the stone. That is for duct stone. Very small stone can be removed by camera, cyeloadenoscopy. 4 to 7, you can break it and you can remove it in pieces by cyeloadenoscopy. More than 7 mm is removed by lay open the duct and take out. If the stone is in the gland, gland contains stone, also called as parenchymal stone. The stone is in this place means we will go for submandibular gland excision. Total gland only, we cannot remove only superficial or deep. Submandibular gland is excised completely. So in this case, though the stone is in the duct only, the gland is not good. It is having cyeloadenitis. So I will go for total submandibular gland excision. Total submandibular gland excision I will go. And the most common nerves encountered while dissecting deep lobe. While dissecting the deep lobe, what are the nerves encountered? Any idea? Very important. There are two nerves which are running in this place. I am drawing in green color here. This is a very important nerve. Lingual nerve can be injured on deep lobe dissection. Lingual nerve can be injured. And another nerve which is going here is hypoglossal nerve. When you lift the superficial lobe, you can see the hypoglossal nerve. So there are two nerves, two deep lobe mobilization we can injure. Lingual nerve and hypoglossal nerves can be injured. So hypoglossal nerve and lingual nerves can be injured in those cases. Please don't forget this point. So what are the two nerves injured? Lingual nerve and hypoglossal nerve are the two nerves injured on dissection. So this is a very important point for your exam. So 5-year-old woman presents with a painless thyroid swelling in the right lobe. FNAC shows it's a case of follicular neoplasm. FNAC shows there is a follicular neoplasm. So please remember, FNAC can only show you it is follicular neoplasm. It cannot differentiate whether it is benign or malignant. It cannot differentiate benign versus malignant, because the concept of benign or malignant is purely based on capsular invasion. It is purely based on capsule invasion. So that is, therefore we cannot find out whether it is benign or malignant. So we can find out only after hemithyroidectomy is needed. Remove the gland, then only you can know from this specimen, hemithyroidectomy, then send for histopathological examination is way to find out whether it is benign or malignant. So follicular cancer can produce most common site of METs. Most common site of distant METs is to skull, is usually to the skull. Skull secondaries are common, and papillary cancer and follicular cancer, both of them take up radioactive iodine uptake is very good. Therefore, for metastatic detection, for metastasis, we use radioactive iodine 131 for metastatic uptake. So once there is a metastasis, and this scan is called as thyroid scan. So when there is a METs, we will give high dose of radioiodine to destroy the METs. But there is a catch point in this question. Please read the question. 5-year-old woman, it's a 55-year-old woman presented with a painless thyroid swelling in the right lobe. FNAC suggests follicular neoplasm. She is planned for thyroid surgery. Wants to know any extra thyroid tissue or any distant spread before surgery. What is the appropriate investigation for this patient? So please remember, to find out extra thyroid or any distant METs, usually we have to go for first total thyroidectomy. So metastatic workup is done after total thyroidectomy only, because If I don't remove the thyroid gland, when I am doing radioactive iodine, all the radioactive iodine will only go to the gland. Metastasis will not be picked up. So metastasis cannot be picked up. So metastatic workup should be done only after total thyroidectomy in thyroid cancer. So therefore, for metastatic workup after total thyroidectomy is done with the help of radioiodine study. Sir, I want to find out the metastasis before surgery. That is the question here. So before surgery, if you want to find out, the answer will be PET scan. So usually we don't use PET scan. So always we evaluate for metastasis only after iodine 131 scan is used for metastatic investigation of choice to detect metastasis in thyroid tumor is a repeat MCQ. It is iodine 131 isotope scan. But if you want to find out metastasis before surgery means we will go for PET scan. So before surgery to find out mets, go for PET scan. So this is a new concept and a new question, but the concept is old, but the question is new. So usually they'll ask you what is the investigation to detect mets. Answer will be straightforward radioiodine. But here they didn't mention after surgery, they have mentioned before surgery. So we should go for PET scan. Okay. A newborn is brought with a large, soft, transluminant, multiloculated cystic mass in the posterior triangle of neck. It is a brilliantly transluminant, not tender, not fluctuant. Overlying skin is normal. Child is stable. No signs of airway compromise or no difficulty in feeding. Everything is normal. Though there is a big swelling, it is not compressing anything. So therefore, what is appropriate management? If there is an airway compromise given in the choice, if there is a breathing difficulty in the choice, I would have gone for immediate surgery. But it is very clear there is no compression. So ideally, in a asymptomatic cases, wait for 3 to 5 years. We can wait for 3 to 5 years in cases of cystic hygroma. This is a case of cystic hygroma. This is a direct MCQ from super specialty books, not from your regular books. This concept is also an old concept, but the question is new. When will you operate? So when there is an airway compromise, surgery excision would have been the answer, but wait for 3 to 5 years. And at 3 to 5 years, we will go for a conservative neck dissection. So neck dissection can be done for at the age of 3 to 5 years is the treatment of choice. We have to remove all the neck nodes. It is due to lymphatic sequestration. Don't forget, it is lymphatic sequestration. So we have to remove all the neck nodes. And there is another treatment which is having high recurrence, that is sclerosant. Sclerosant injection can be done, but it has more chances of recurrence. Using picibanil is now not advised because increased recurrence are seen in these cases. Since the cyst is multiloculated, this is not going to cure it completely, so there is more chances of recurrence. So from this question, we will go for operate at 4 years of age. So ideally, we operate at 5 years of age is ideal answer, not 1 year. We don't operate 1 year or immediately, and we should not aspirate. We should only operate, remove it. Surgical excision is done, but it is at 5 years. So these are the questions from head and neck, thyroid and breast. We had some good number of questions from head and neck, thyroid, breast. Now we go to the GIT. A 55-year-old man presenting to emergency department with a sudden retrosternal chest pain, retching and vomiting after a heavy meal and alcohol intake is having chest pain, vomiting. So what is this? So this is a classical history mentioning about Mackler's triad. So Mackler's triad is a feature of Boerhaave syndrome. It's a feature of Boerhaave syndrome. In Boerhaave syndrome, there will be vomiting followed by chest pain, followed by subcutaneous emphysema. Is Mackler's triad. So Boerhaave syndrome is characterized by vomiting, chest pain, subcutaneous emphysema, and these patients have a rupture of esophagus in the lower end like this. So they have a ruptured esophagus in the lower end. So that is causing this Boerhaave syndrome. So this is an emergency called as Boerhaave syndrome. So what should I do? Immediately you should confirm this rupture by doing a CECT chest. CECT chest is an investigation of choice, and treatment of choice is emergency thoracotomy and repair. Emergency thoracotomy. Immediately thoracotomy you should do and repair the injury, repair the rent in the esophagus. This is a Boerhaave syndrome. Again, a favorite question of FMGE exams. Always they ask a question from Boerhaave syndrome. A male child is brought to emergency OPD, so brought to surgery OPD with the inguinoscrotal swelling. Swelling shows when the baby is crying, the baby is getting a small swelling extending to the scrotum like this. There is a swelling extending to the scrotum like this. In the small child, there is a scrotal swelling extending and descends downwards like this. And afterwards, when the baby lies down, it goes inside. What is the most likely diagnosis? So the answer is very clear cut. It is a indirect inguinal hernia. So swelling increases when crying during micturition and descends medially. This is a classical indirect hernia. So please remember, most common hernia in children. Children answer is indirect hernia, which comes through deep ring to superficial ring. Please remember the anatomy of hernia. In young adults, what's the answer? In young adults also it is indirect hernia, deep ring to superficial ring. In females also the most common hernia is indirect, which is from deep ring to, so see, in all these people, children, young adult, females, the commonest hernia is indirect hernia. In old men, what's the commonest hernia? It is direct hernia, which comes through Hasselbalch triangle, which comes out of Hasselbalch triangle. So direct hernia and indirect hernia are easily differentiated during surgery by watching for the inferior epigastric artery. Any hernia coming lateral is called as lateral to inferior epigastric artery is indirect hernia. Any hernia coming medial is called as direct hernia during surgery. Medial is called as direct hernia. So during surgery, I can easily differentiate whether it is indirect or direct by seeing the inferior epigastric artery. And femoral hernia is a very, very rare hernia. So far, I have operated only 4 cases. Femoral hernia is most common in females than males, and it is very, very rare hernia. Okay, don't forget, femoral hernia is very, very rare hernia. It is common among females and very, very rare in males. Okay, so this question is therefore a straightforward question of indirect inguinal hernia. A 2-year-old child is brought to the hospital with a recurrent protrusion of red circular mass through the anus. So red circular mass means like this. A circular mass coming out of the anus is nothing but rectal prolapse. So child has chronic diarrhea and poor weight gain. So because of diarrhea and weight gain, the rectal prolapse has happened, and the prolapsed mass is moist, concentric, and this mass, when I push, it goes inside. What is the appropriate management means? Every time when this comes out, we should digitally reposition it and improve the nutrition. So digital reposition is enough for pediatric cases. So same rectal prolapse in adult patients. Adults coming to you with rectal prolapse have 2 options: abdominal approach and perineal approach. We can operate through abdomen or through perineum. Abdominal approaches are called as modified Ripstein. The name of the operations are modified Ripstein. Mesh repairs, ventral rectopexy of D. Moore operation, D. Moore. Another one is abdominal approach, where we fix the rectum to the sacrum. Another one is Friedman-Goldberg. Friedman-Goldberg is another operation. So these are all abdominal operations. For unfit old age patients, we do perineal operations. They are called as Triage, Delaunay, Altimer. This is a common MCQ, already many times asked. The following are the perineal operations except will be the question. Triage, Delaunay, Altimer are done through the anus. Other surgeries are done through the abdomen. So this perineal surgeries have high recurrence. High recurrence is seen in perineal operations. Just remember these names. 25-year-old patient comes to you with recurrent abdominal pain, weight loss and diarrhea. So image of barium meal follow through as well as MR enteroclysis. This is image of MR enteroclysis. This is MR enteroclysis. This is barium meal follow through. So I don't know which exam image was asked in the exam. But the finding is same in both. You can see here there is a stricturous sign called as string sign. Here also you can see a string sign. So this is called as string sign of Cantor. String sign of Cantor is a terminal ileal narrowing. It's a narrowing of the ileum seen in Crohn's disease and also in TB. So both options are here. You can see TB is also there, Crohn's is also there. Which will I go for now? So from the history, you can see weight loss and diarrhea are more prominent in Crohn's disease. So if there is a fever, evening rise of fever, contact history of TB, something is given like that, I would have gone for TB, and this is a Crohn's disease. So not TB, okay, this is not TB, it is Crohn's disease. So Crohn's disease most commonly affects ileum, terminal ileum, that also terminal ileum. And here it forms here stricture, that is what you are seeing in this case. Stricture is a common cause of, most common indication for surgery in Crohn's is stricture causing obstruction. Most common indication of surgery in Crohn's is stricture causing obstruction. That is the case of Crohn's stricture. So a few questions from hepatobiliary. A patient undergoes liver surgery. Post-operatively, bilirubin levels are remains elevated. Despite the treatment, laboratory elevation show elevated direct bilirubin, but unconjugate bilirubin is normal. There is no increase in urobilinogen. Which of the following is primarily responsible for bilirubin? So this you should understand biochemistry. Bilirubin, when we do liver function test, is of two things which are done. So one is indirect bilirubin. Another is direct bilirubin. So direct is nothing but conjugated bilirubin. Indirect is unconjugated bilirubin. So both are usually measured. So normal value of bilirubin is less than 1 milligrams per deciliter, and this is the common value, less than 1 milligram per deciliter is a normal bilirubin value. If there is increase of indirect bilirubin, which condition you have increased indirect bilirubin, it is medical jaundice. In medical jaundice, what are the medical jaundice cases? So you know all the cases of medical jaundice like cirrhosis, viral hepatitis, and drug-induced hepatitis. All these cases will have indirect bilirubin elevated. Apart from indirect bilirubin, they will also have increased AST and increased ALT. Nothing but aspartate transaminase and ALT also will be elevated in unconjugated or medical jaundice. Direct bilirubin is increased in surgical jaundice. Surgical jaundice are nothing but obstructive jaundice, like a stone obstructing the bile duct or a cancer obstructing the bile duct. In all these cases, direct bilirubin will be more elevated than indirect, and they also have increased alkaline phosphatase. So just with the help of LFT, I can say whether it is a surgical jaundice or a medical jaundice. So elevated direct bilirubin is nothing but conjugated bilirubin. It is a conjugated bilirubin in a medical jaundice in this patient. Probably this patient has developed a liver failure after surgery. Liver failure after hepatectomy has happened in this case. So this is a new question, but it is more of a biochemistry oriented surgery question. Okay, please remember conjugated bilirubin is elevated. 42-year-old man with a history of chronic alcohol intake presents with recurrent epigastric pain radiating to the back, weight loss and steatorrhea. So steatorrhea means the pancreas is gone. So this clinically the diagnosis is chronic pancreatitis. From the history it is chronic pancreatitis, and image is now confirming. Investigation shows pancreatic calcification. So in pancreas, if there are stones like this, it is undoubtedly a case of chronic pancreatitis. There is no head mass, no obstruction, no suspicion of malignancy. So what is the most appropriate initial man? They are asking what is the initially, what I will do. Because the pancreatic enzymes are deficient in this patient, pancreatic enzymes are deficient like lipase, amylase, all are deficient in this patient. That is one of the reason for developing a steatorrhea. So first of all, let me improve his nutrition by giving pancreatic enzyme supplements like pan-lipase or pancreatic enzyme supplement. Many drugs are available, Creon, Pancreoflat, all these are drugs available in the market as pancreatic enzyme supplements. This should be given along with the meals. Along with the meals, when you are eating, you should eat in between the meals, you should eat the pancreatic enzyme tablets. It will stop that steatorrhea and it increases weight gain and decreases steatorrhea. This is first important thing. Afterwards, we will discuss about pain management. First, we should correct the steatorrhea and the nutrition. That is answer for 19th question. This is also a new question, new concept asked in FMGE exam. So, new question on chronic pancreatitis going for steatorrhea. This is a new concept asked in your exam. A surgeon is performing laparoscopic cholecystectomy for acute cholecystitis. Intraoperatively, the gallbladder is very big distended and dense adhesions are seen in the Kellogg's triangle. See, this is the liver. Assume this is a gallbladder you are operating and this is the Kellogg's triangle. Hope you know read the Kellogg's triangle anatomy. So, this area is fully frozen, very difficult to operate. So, and the surgeon trying to remove this, he found out there is a stone in the bile duct also like this, and therefore during surgery he injured this bile duct also. So, during surgery the common bile duct is inadvertently injured, resulting in leakage of bile intraoperatively. Surgeon is not experienced in advanced laparoscopy, means if you are an experienced surgeon, laparoscopically you can open this duct and laparoscopically we can repair the injury. But what is the appropriate step for a not experienced in laparoscopy? Means all surgeons will be experienced in open surgery. Convert the case to open. Convert the case to open and just put a T-tube. Remove the stone and just come out keeping a T-tube into the bile duct. This is the safest surgery. So, remove the stones, remove the gallbladder and close the rent using a T-tube. So, convert to open surgery and perform CBD repair with a T-tube placement is the correct answer. So, we cannot go to ERCP, already the surgery is going on. So, close that tear laparoscopically and insert an abdominal drain can be done by experts. So, experts can do this. So, experts, we cannot continue laparoscopy and complete cholecystectomy later. That is also not done. So, experts can repair it laparoscopically, but inexperienced surgeons will keep a T-tube inside. That is a simple, straightforward, practical question. So, coming to specialty surgeries, some questions are being asked. So, all questions are very big. You can see in FMGE in this exam, many questions are very big, wasting most of your time, and that is why I told you it's a moderate to tough paper. 68-year-old man with a long-standing urinary tract symptoms has BPH and undergoes TURP, transurethral resection of prostate under spinal anesthesia. During procedure, fluid of choice for TURP is naturally it is isotonic glycine. Isotonic glycine is an ideal fluid which is also used as an irrigating fluid. After 5 minutes as the surgery is going on, patient developed restlessness, headache, nausea, vomiting, bradycardia, hypotension and confusion. That's a clue. When surgery is going on, because it's a spinal anesthesia, patient will be awake only. He's telling, sir, I'm confused, I'm getting vomiting, something is happening like that. Immediately you should do an on ECG monitor. You are seeing prolonged QT interval and you are doing a serum sodium which is normally 138 or above is now 118. So, the patient has developed dilutional hyponatremia. This is called as water intoxication or dilutional hyponatremia is a complication of TURP. So, what should I do immediately? Immediately stop the procedure and infuse hypertonic saline should be infused in this patient. That is, abort the surgery and give hypertonic saline. Okay, abort the surgery and give hypertonic saline. And when we are doing surgery, this is very important step you should do. So, we will not give normal saline. Normal saline is not used during TURP because it cannot properly cut the tissue. Continuous surgery is absolutely wrong in an hyponatremia case. Stop the procedure and give furosemide is also wrong. So, ideal procedure is give hypertonic saline infusion. So, correct sodium. Sodium decrease should be corrected. This syndrome is called as TUR syndrome. Usually this happens in the post-operative period. This is already an old question. Transurethral resection syndrome developing in the post-operative period. In this patient, it developed during surgery itself. So, 32-year-old man develops deep dermal burns, underwent skin grafting. This is a straightforward question. There is a split skin grafting which is nothing but partial thickness graft. Split skin graft is a partial thickness graft. So, this is a straightforward image-based question, already many times asked repeat question. See, split skin graft is a partial thickness graft used for skin grafting. So, split skin graft is done if the donor area is having good vascularity. Donor area is vascular. Okay, don't forget split skin grafting. Long-term complication of split skin grafting is it can go for secondary contracture and the wound may look ugly. Cosmetically ugly looking after 1 month or 2 months. Cosmetically ugly looking in future. This graft will go for contracture and it looks ugly after some years. According to CEAP classification for chronic venous disease, all of you know there are C1, C2, C3, C4, C5, C6. This is a CEAP classification. C1 is telangiectasia and reticular veins. Reticular veins. So, less than 1 mm is telangiectasia, 1 to 3 mm is reticular veins, more than 3 mm varicose vein is C2. C3 is edema. So, these are straightforward simple 3 points, C1, C2, C3. So, this patient is having telangiectasia and reticular veins, so I will go for C1. C1. C4 is further divided into many, I will tell you. C5 is healed ulcer, a healed venous ulcer. C6 is active venous ulcer. C4 is what? C4 is very important. Please remember, C4 is skin changes. So many skin changes are given every time you get in exam. C4A is eczema. C4A is eczema. B is lipodermatosclerosis and atrophy blanchi. And C4C is corona phlebitica. Corona phlebitica. It's a new update. It's a small lesion in the ankle. So, A is eczema, B for lipodermatosclerosis, C for corona phlebitica. Is a repeat question, CEAP classification and all. Without reading, you should not go to the exam. So, 24 years old intravenous drug abuser presents with pulsatile mass in the groin. There is a pulsatile. So, whenever it is a pulsatile mass, it may be an aneurysm, infected aneurysm. So, when you palpate, it is having warmth and tenderness suggestive of infection. So, it is an infected aneurysm, also called as pseudoaneurysm of femoral artery. Femoral artery. So, this is called as mycotic aneurysm. Though mycotic means fungus, it is misnomer. It is caused by bacteria, usually Staph aureus. This is a case of mycotic aneurysm seen in the groin. What should I do to confirm the diagnosis? Means ultrasound Doppler is the next investigation to confirm. Without knowing that, if you go and put a blade, bleeding will happen like anything. If you go and put a knife and drain it, thinking an abscess, it will bleed like anything. So be careful. This is a classical case of infected aneurysm called as mycotic aneurysm. So we had around 24 straightforward questions from surgery and some questions from applied anatomy and other physiology and biochemistry that in the paper 1. So, you would have read those questions, but these are the paper 2 24 surgery questions which I could get from the students who wrote the exam. So, be thorough with the concepts. Concepts always repeat in FMG. So, concepts repeat, not the fact, not the same questions. So, I always say read the concepts. They will again and again repeat. So, reading the concept is very important in FMG exam. So, all the best for your June 2026 FMG exam. I am sure you will get at least 6 to 7 questions from this 24 questions. All the best. Thank you.